doing the right thing at the right time, and what could we be doing better? You can all read Albert's CV, so I will not go into it, and let him talk about the dynamics of contract. Some people call it toll plasma fractionation. Albert.
Well, this is the second time in less than 12 months that I've had the great honor of being introduced by our illustrious chair, for whom I have a huge personal regard and affection. And we know about Cefadex, John, because of you, primarily. So I think this industry needs to always acknowledge your own huge contributions. I'm, as always, happy to be at the IPPC and maintain my quasi-unbroken run, especially in the glorious capital of Catalonia. I would like to express this disclaimer. This is something which I do as a matter of course in order to keep myself out of trouble. It doesn't work all the time, but I feel obliged to do it. I'm not deeply conscious of the fact that I can see my boss looking at it with great interest. Okay. All right, so look, I don't think the slides are on the USB, but anybody who wants them can ask me for them, or they'll be on the website, so just don't take any notes, but I put to go over about 30 slides, so just give me your attention. So this is a basic summary, as usual, extracted from MRB in relation to the capacity vis-a-vis contract manufacture. And you can see that overall it keeps increasing in relation to contract manufacture, and as usual, the commercial sector bears the brunt of the burden in relation to this aspect of the industry. Patrick yesterday gave the latest updates on global fractionation capacity, and I had a conversation with him just a few months ago when I was thinking about what to say at this talk. And the idea, the projections are somewhat as you see them on this slide, and there therefore is a possible excess capacity of about 17 to 18,000 liters, based on an estimated throughput of 40 to 45 vis-a-vis the likely capacity. Now you might say therefore that we do have a level of excess capacity which can be dedicated to contract manufacture. But I think the picture is a bit more sophisticated than that. If you look again at Patrick Roberts' data and MRB's data in relation to plant throughput, you can see the results here vis-a-vis the commercial and the not-for-profit sector. And both sides have a certain level of average throughput which is below their hypothetical capacity. And so you might think that, yeah, it's possible to run the plants harder and get more plasma through if plasma can be generated and therefore have a capacity for contract manufacture. This is a bit simplistic. This is thinking in which I was assisted by Larry Kaheen, who is obviously much more experienced in this kind of thing than I, but it is the case that in any kind of engineering system, I think you cannot afford to think in terms of running the system at 100% of its theoretical capacity, because basically then you will come close to blowing its brains out. And so we mustn't think that in plasma fractionation, because we have a plant which has a certain capacity, we can actually run it all the time at that level. We do need to take into account time factors for preventive maintenance, shutdown, and so on. This is, I think, a reasonably important point. However, throughput does need to be maintained, and this is a slide from Jan Bult from an IPPC, which was noted because I had a conversation there with him. This was about 8 years ago, and it was a conversation which led to a remarkable change in my own life, because it led to me joining the PPTA. You can see that when we start to decrease throughput, and this can happen if we don't have enough plasma to push through, we get a remarkable increase in the costs. This is very important in terms of contract manufacture, because you can have very good intentions in absorbing plasma from areas outside one's, so to speak, traditional catchment area for plasma, but it can lead to serious effects if this supply cannot be maintained. And this is something which has been known to happen, and I have seen it happen in my experience when I was a regulator in Australia, having the honor of regulating a somewhat large company not unrepresented in this meeting. So I'm going to talk a bit about how this bears on the economics of plasma, and much of this I think is very familiar to you in relation to what are our basic costs related to the revenue. And I have tried to summarize the pros of contract manufacture from the point of view of the fractionator and the point of view of the client in relation to the headings which you can see over here. And I will explain these as I go along. This is a kind of personal distillation of some thinking which was expressed by another person in this audience, Francois Falsou, in a meeting which we had in Brazil many years ago. And my memory is a bit hazy because it was some years ago, and I can remember other things occurring during this meeting in Brazil which tended to obscure the memory even more. So we talk about capacity. Let's talk a bit about how this relates to revenue. This is a slide taken from a public document, and I actually found this document, and I am obliged to John for pointing me to this. This is a document from Grifols, to be immensely informative in relation to many aspects of this industry which we know about, but which are seldom seen in the public domain. And this shows Grifols' perception in relation to the concept of first liter fractionation in terms of taking out all the major proteins which yield a certain level of revenue. And you can see this over here. This is a somewhat more detailed assessment of the same aspect taken from the book which was edited by, amongst other people, John Curling some years ago, a very good book, required reading for anybody in this industry, showing the relationship of gross margin to the various stages which one goes through as one fractionates the first liter and so on, and until going to the last liter. I mean, I think we can accept that every last liter of plasma will extract immunoglobulin because of the huge demand, which shows no sign of real decrease. But we will start taking out less proteins as proteins in less demand, such as albumin and factor VIII, start not being taken out. So we can see the effect of this on the economics of the fractionation. So how does this bear up with contract fractionation? Well, one might argue that, I've got spare capacity, I'm not taking out all the proteins which I can take out for my traditional market. I might as well absorb some of the spare capacity with a contract manufacturer. Okay, very well and good, but one must remember that there needs to be the retention of a certain level of nice footwork in the industry, in the sense that some capacity in reserve for taking up extra demand from the traditional market is economically sensible. And this might affect the strategic direction in absorbing contract manufacturer type inputs. It is not as easy as it appears on the surface. Let me say something about now the market entry argument. We all know that there are markets in which there are certain constructs, and yesterday they were brought up peripherally, under the umbrellas of so-called self-sufficiency, in which direct importation of products on an open market is to a greater or lesser extent restricted, and this is a concept which we've discussed ad nauseum in this meeting, and as I said yesterday, some of these arguments I'm starting to find very boring, but the argument is that if you introduce yourself through a contract fractionation type scenario when local factors impede the normal market access, then you are able to access some level of market presence in the relevant country. And this is sometimes possible when there is no national fractionator, and we have contract fractionation situations involving various companies like Optopharma, LFB in Brazil, and so on and so forth. It's interesting to note from an extract in one of the most famous documents generated as a result of the viral problems in the 80s and 90s, from Horace Creever, that he said that the principle of self-sufficiency doesn't necessarily mean that you have to have plasma fractionated by domestic fractionation capacity. He said this in the context of the Creever inquiry, because at that time Canada did have a fractionation plant. It was the Connaught Laboratories, and it was found as a result of his inquiry that it was better to close this as soon as possible and say nothing more. He said this in this context. I've also got some thinking about what I call the local knowledge argument, that a sort of knowledge of the local environment by a local fractionator is able to exert traction in a contract manufacture, and this offers significant benefits. It is the case that companies like Kedrion in Italy and CSL in Australia have gained over many, many years of a strong market position in relation to contract fractionation, a very strong knowledge of the local transfusion system. This cuts both ways, because sometimes it makes you want to run away screaming from the contract rather than to actually chase it, but it is the case that the best people to assess the system is the contract fractionator in situ. It does require a lot of trust and sensitivity to the clinical needs. And it does generate, and I've seen this happen myself in the landscapes I have occupied over my career, sometimes a level of resentment if this local presence is accompanied by a restriction in clinical choice. This sometimes happens. And there are many things to be assessed in this, particularly, and I'll say something about the aspects which I'm most familiar with, the regulatory system, but also the relationships to the medical and the patient community. Then there's the technology transfer argument, and we've seen this being proposed, that contract manufacture can be introduced as a route to familiarization with a developing fractionation landscape and providing technology transfer for local endeavors in constructing plants. There's the long-standing, and I have no idea at what stage this massive project is at now in Brazil in relation to the attempt to create a fairly modestly sized plant in the state of Pernambuco. I always thought that this was a very strange place to put a plasma fractionation plant in, and I have no knowledge as to the progress of this plant. Every 5 years I hear talks which claim that it's going to be up and running in the next 5 years, and they did have a website in which they had some pictures, but they were cartoons, not actual real photographs. And that was, I mean, I don't know if it's successful. Perhaps people here have an idea. I do know CSL endeavored to try to generate a similar project in Poland many years ago, sometime in the mid to late 90s, and it was not successful. It is not an easy thing to do. I'll now look at a few aspects from the punto de vista of the client. One of the most interesting arguments which I've been made familiar with, especially in my environment in Australia, is the argument of quality, that contract manufacture in the plasma fractionation landscape can act, as you like, as a catalyst to improving quality in the mainstream blood service, since in the vast majority of instances, contract manufacture is done on recovered plasma acquired through whole blood. This is an interesting argument. It does need to acknowledge that the introduction of quality standards may ripple through the rest of the blood system, but this is not necessarily always the case. In Australia, for example, it was interesting. I was a regulator in Australia for about 15 years, and for the first part of that time, we only regulated, in terms of the products of the transfusion service, plasma for manufacture, which was most of the recovered plasma. In fact, at this time, Australia was in the luxurious position of collecting an excess of red cells, and red cells were actually systematically collected in excess, knowing that the red cells would be discarded because of the need for plasma for fractionation, something on which I have a view which I don't need to share now, and which is only a historical artifact anyway. But we did regulate plasma for manufacture under a code of GMP, a specific GMP code. So we thought, well, this means that effectively the safety of the rest of the blood system is being effectively assured, because most of the safety requirements are being imposed through the recovered plasma requirements. Then in 2000, as a result of a long series of negotiations, we took over the regulation of the rest of the blood system. We found that our optimism in relation to the quality and safety of the blood system because of plasma for manufacture was not fully justified. There were a lot of gaps in the system. So this is not always the case. And it doesn't mean that assuring the basic safety and GMP of component manufacture actually always assures the plasma system. For example, we had an incident in Australia, public information, which led to a parliamentary inquiry in which I experienced many hours of anxiety, being grilled by the Australian Senate, in which plasma, which was HCV positive, was actually systematically and deliberately introduced into the plasma pool to make products which were administered to patients. Overall, this is a positive factor. Now I'm saying something about regulation. This is a slide captured from the Bioplasma meeting in Shanghai last year by one of the colleagues at the Paul Ehrlich, and she was specifically charged with talking about regulatory requirements related to contract manufacture. So basically you can see here that you've got the nexus of requirements. This is just in relation to the European Union. The nexus of requirements which are in place. Now, as I, dissect through the complex and in many ways incomprehensible labyrinth of requirements, I see that in relation to contract manufacture coming from outside the EU, there is, for example, apparently no plasma master file requirement as stated. There is a whole raft of directives, some of them truncated, as you can see only Annex 5 of Directive 2004/33 is applicable, and so on and so forth. This is the sum total of the regulatory framework for plasma and plasma-derived medicinal products for the European Union. So you can see that this is very large and comprehensive, and therefore only a relatively modest portion is actually brought to bear on contract manufacture. And these are the key provisions which are brought to bear. The first one is Annex 5 of the quality and safety requirements for blood and blood components. I don't want to bore you with these regulatory documents. The point I seek to make on Annex 5 of Directive 33 of 2004 is that the requirements relative to plasma for manufacture are actually very modest. You can see there that there's a bunch of requirements relative to the quality, and they are fairly modest, and I would propose, John, most of them are fairly relevant as well to the requirements of fractionation. One of the very important aspects, of course, is the testing requirements in regards to viral markers. Again, these, relative to what the industry actually considers as its own standards, are, in terms of the the mandatory requirements of the regulatory system in Europe, again, relatively modest and minimal, and consist of the basic serological markers, with the caveat that additional tests may be required for specific situations. And we do see this happening. First of all, there is a requirement in relation to NAT for hepatitis C, but it's still at the level of the so-called first homogeneous pool, which means that it's basically not a very sensitive requirement, as you know. But many fractionators and suppliers are obviously wiser than that, and they do include more rigorous requirements in their contracts. For example, Biotest, in relation to Iran, as was explained in a conference in Iran I was at 5 years ago, have a 5 viral NAT. Overall, regulation is essential, and this is the main reason why I'm interested in contract manufacture, because contract manufacture for a regulator is a big political headache, especially when there is a domestic fractionation plant charged with national requirements, as there is in Australia, Italy, and so on. And we had a huge political flurry in Australia in the late 90s, for example, when we had a publicly observable incident involving the importation of plasma for commercial use into the domestic plant, and our political masters considered that this was done without the adequate permissions and so on, and we had a parliamentary inquiry and grilling by the Senate and so on. And this explains why regulators, including, for example, the IFA in Italy, certainly the TGA in Australia, where I was and so on, are so paranoid about the issue of contract manufacture, because they are always afraid that this filthy overseas foreign plasma will somehow contaminate the purer than the driven slow domestic supply. I'm putting in dramatic terms what I know to be in their minds. And so you get these very, very strong, rigorous requirements by the local authority, which lead to impediments in the basic commercial running of the operation. And this is something which has to be always considered by the agencies in place. There are many underestimated problems. I reiterate again, blood systems which generate recovered plasma anywhere around the world are not really geared to the concept of pharmaceutical manufacture, and nor should they be, because it's not their job. Their job is basically to produce transfusion components for clinical use within a hospital system. The generation of plasma for manufacture is best done by companies who are actually going to fractionate and already operate under a GMP environment. This is always the system. For example, in Australia, again, I had the somewhat sad task of making a strict assessment in the late 90s on the desirability of getting plasma for manufacture from the regional blood centers of Southern Australia, which is one of our states. It was clear that these suppliers, these small hospitals supplying plasma for fractionation, did not come up to GMP. Furthermore, they were producing only a very modest amount of plasma. So, obviously in conjunction with political authorities and taking a deep breath and saying some prayers, I closed them all down. There was no other thing to do, because their job was not to supply plasma for fractionation. Their job was something entirely different, and the continual use of small amounts of plasma not collected under GMP could not be justified. I think that I have already stated what I think is the solution, and this is personally what I would like to see happening everywhere. Having said that, it is the case that the quality argument does come into place, and again, this is a slide extracted from that meeting in Iran some years ago, whereby you can see that the percentage of plasma discarded for unsuitable use decreased over the years as the Biotest-Iran relationship led to a clearer understanding of quality in the plasma and therefore less product being discarded, which of course then feeds into a better quality in the overall blood system. So one has to The cost of plasma is a substantial cost, as we know, in fractionation. It has been shown several times, even in this meeting. So you can save through providing your own. Again, this is semi-fallacious. Ensuring quality and GMP as a minimum standard in a naive environment, that costs a lot of money. To bring them up to scratch and generate the ability to produce pharmaceutical-grade raw material, this is something which is impossible to inoculate in a hospital system, despite all the best intentions in the world. It's very, very difficult to inoculate this argument, and it costs a lot of money. This is the other thing. Probably you need a threshold of about 30 tons of plasma and 3 products. This is again from Dr. Falsu. I don't know if he still has this idea. I personally think that a threshold of 30 tons is way too little, and that you need more. It could be a useful source for technology transfer, as we have said, but the operating cost for a small domestic plant is definitely higher than for large commercial manufacturers. It's always the way, economies of scale. Of course, you can think in terms of regional options. For example, when in the early 2000s, I first heard about the Pernambuco project in a WHO meeting in Hong Kong in 2000. And I thought, yeah, this is a great thing, because if Brazil has a big fractionation plant, it might be able to supply the rest of the region. And then Brazil declared its intention to have a 250-ton fractionation plant. This for a population of 200 million, which is a joke. And then they compromised and said, okay, we'll have 500 tons. Well, I can tell you that the plant in Australia for the contract manufacturer domestically has a capacity of 600 tons, and it's not enough. So for a population of 24 million. And the danger in this is that it then gets geared to the self-sufficiency argument. And patients end up on a rationing type situation because the plant for domestic use is just not big enough, apart from the fact that they don't make enough plasma. So, you know, pros and cons. Linked to this is the surplus plasma argument that, you know, nowadays we know that there's no such thing as blood transfusion. It doesn't exist anymore. What we have is red cell transfusion. We generate plasma from whole blood donations through a recovery mode, and this means that we have a lot of plasma. So we've got to do something with this. Now, I've written a lot about this, and you can look them up if you're interested, and I have, again, somewhat strong views. But it would seem logical that since we've got all this plasma anyway, because of our adherence to the idea of component therapy, that we should then convert it into products. Well, the fact of the matter is that we've said already the cost is high, the quality requirements are high, but the important thing is that thankfully, finally, after decades of biting gas, evidence-based medicine is starting to bite the transfusion sector, and less red cells are being transfused. And this means that the red cell amounts are going down, the amount of recovered plasma is going down, and therefore there will be less of a supply of recovered plasma. And depending on it is not a good idea. Again, the solution is dedicated collection through apheresis. Last point in this regard is the argument, which I think is quite a well-considered one, of customer specificity, that a local provider of plasma can incorporate into the contract specific requirements, not only from the client's point of view, but also, for example, from the regulatory authorities' point of view in relation to public health needs. An example, in Australia we have no variant CJD, never had it. We are as pure as the driven snow, even though we have all these cows, which are fed kangaroos sometimes, but they're not fed cows, they're fed kangaroos. This is the truth, incidentally. And therefore we were able, in the early 2000s, to impose a specific requirement on the local fractionator for factor VIII for patients in Australia, whereby we excluded totally any donor who was exposed to the possibility of being in a VCJD environment. This, I think, was an interesting example of how you can tailor to the public health needs. But also you can tailor to the needs of the client in relation to how much product you make, more or less albumin, more or less factor VIII, and so on and so forth. I just want to say a quick word, and I know that Alan Whale is here. This is a subject which is of great interest to us in the World Federation of Hemophilia, on the question of surplus proteins. Because depending on the product mix and, of course, what you make, you can generate a surplus to what the client actually wants. It's generally the case that a surplus of albumin can easily be generated. A surplus of plasma factor VIII is generally easily generated. So what do you do with these? Do you just not take them out? Or do you take them out and sell them? Well, there are interesting examples. For example, the plasma under contract to CSL in Australia by the New Zealand Blood Service generates surplus albumin, which is sold on the market and which is then part of the revenue is pumped back in the New Zealand Blood Service, which I think is a very commendable thing. Or you can generate a humanitarian aid effort, and we know about the efforts involving Biotest vis-à-vis the Canadian cryo, and Cadrion and the Italian blood system vis-à-vis the huge amounts of factor VIII generated in Italy. There's a continuous ethical debate on this, on whether we should commercialize product from voluntary donors, but I just make the comment that actually New Zealanders are immensely ethical people and they can live with this. I think this would be a very good thing myself. So look, John, I'm just going to end with some tentative reflections. I don't like to call anything conclusions these days. I think that contract manufacture demands a very well-resourced regulatory system and the sensitivity to political factors. It's not just a case of providing the plasma. The global surplus fractionation capacity, as I see it, I don't know what Patrick Robert thinks, is relatively modest. I don't think there's that much surplus capacity. Ultimately, we are going to have more plant capacity, and obviously that's being generated all around the world. Nevertheless, we do have high-quality programs for contract manufacture, and as the clinical demands increase in emerging markets, we may expect to see more of these programs. Ultimately, the increased demand, as I said, will need more plants, possibly through technology transfers I have outlined. Just want to thank Larry Kaheen and John Carling for generous gifts of ideas, corrections, and slides. They are in no sense responsible for any of the opinions expressed in this talk. Thank you very much.